Faculty and dear delegates, a very good evening to one and all. I, Dr. Tanmay Rane, feel very privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present Empower Talk, our highly anticipated scientific program dedicated to exploring the multifaceted landscape of diabetes management. This program serves as a bridge between knowledge and practical application aimed at equipping us with the tools needed to enhance the lives of patients affected by diabetes. Our distinguished speaker today is poised to share his knowledge, insights, and practical wisdom to empower us in the fight against this health challenge. We are thankful to our esteemed speaker, Dr. A. Paniraselvam Sir, who has generously decided to share his time and wisdom. Emcure is privileged to have a role in facilitating this bond. Let me have the privilege of introducing our esteemed speaker for the program, Dr. A. Paniraselvam Sir. Sir is a consultant diabetologist at Aruna Diabetes Center at Chennai. Sir was the former assistant professor of diabetology, Kilpauk Medical College and Government Chennai, chairman of Lion KRS Insulin Bank for Juvenile Diabetics, co-chairman Diabetes Association of India, Southern Chapter Chennai, vice chairman of the Research Society for the Study of Diabetes in India, former project coordinator, World Diabetes Foundation and Gestational Diabetes Mellitus Project, Tamil Nadu. Sir has received the Best Doctor Award from the government Royapath Hospital, Chennai, recipient of the Diabetes Awareness Initiative Award, Diabetes India 2015. Sir has contributed to original articles on diabetes in international and national journals. Finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me now brief you on the agenda for today's program. We will first have the expert session on today's topic, followed by the Q&A session. So I would request all the audience to kindly post their questions in the comments box so that we can take these questions up in the Q&A session. Without further ado, let us embark on this educational voyage together as we endeavor to enhance our understanding of diabetes management. I would now request our speaker, Dr. A. Paniraselvam Sir, to deliver his session on the role of pioglitazone-based combination therapy in diabetes management in the current era. Over to you, sir.
Thank you, Tanmay. Thank you. I will share the slide from here. You close your slides.
Yes, yes.
Closed it?
Yes, sir, closed.
Right. Thank you, Tanmay. Thank you, Rikshi, and entire Emcure team for taking up this topic, because the armamentarium for treatment of diabetes is keep on increasing. So I'm in practice from 82. Before 82 or even up to 2002, the available class of drugs were to start with insulin from 1922 till today. Then 1956, sulfonylurea and bigonide started entering. And regarding bigonide, we had penformin and metformin. Penformin had gone out. Metformin still we are using. Regarding sulfonylurea, carbutide was the first sulfonylurea, which Dr. Viswanathan and Dr. Samji Moses, they're all our professors, they used. But our generation used albutamide, chlorpropamide, glypyside, glibenclamide, glycoside, then lastly glimepiride, 1996. Otherwise, up to 2000, these three classes of drugs, sulfonylurea, biconite, and insulin only were in use. From 2000 onwards, alpha glucosidase inhibitors, TZDs, that is your pioglitazone, gliptins, sitagliptin, vildagliptin, linagliptin, etc., glipizins, dapagliflozin, empagliflozin, canagliflozins, and recently glimin, imiglimine, and GLP-1 receptor analog like your exenatide, liraglutide, exenatide, all those things. Otherwise, 6 new class of drugs, they're all non-sulfonylurea molecules and non-insulin molecules, along with the metformin, doing wonderful management in the treatment of diabetes, about which all practitioners involved in diabetes care should understand. Because we were fighting against diabetes earlier by upwardly titrating either sulfonylurea or insulin along with the metformin. During this fight, almost 20 to 30% of the people are not responding for this kind of treatment. And many of them face hypoglycemia because of insulin and sulfonylurea. If they delay the food, or food intake is less, or the quantity of insulin is more, or sulfonylurea is more, or exercise is excess, invariably they face hypoglycemia. They fear to take medicine also. They stop medication also. They land up with complications. This was a story up to year 2000, 2002. After the arrival of AGI and TZD and gliptin, recently SGLT inhibitor, glimin and GLP receptor analog, the scenario is totally changed. We were able to maintain beautifully the blood sugar well, and we can avoid complications. We can prevent diabetes complication. Smooth control without causing glycemic variability, it is very much possible. Among these newer classes, TZD is the senior most. Of course, acarbose got introduced in 97. TZD got introduced in India in 2000. Gliptin got introduced in India in 2007. We have 15 years of experience with the gliptin and 23 years of experience with the TZDs. So with these two molecules, we are in a better position to control. Of course, SGLT inhibitor is helping us. GLP-1 receptor analog also helping us to a certain extent. What we are going to discuss today is the role of TZD and gliptins. Among TZD also, rosiglitazone had gone out of market. Pioglitazone, it was in use from 2000 to 2013. Initially, we were fearing about liver failure, jaundice, etc., because the earlier molecule caused problem. We monitored, it was not causing the problem. Then we started observing weight gain and pedal edema. Then we started observing cardiac failure, especially in cardiac failure patients. This was the drawbacks or adverse effect of the pioglitazone. Then 2013 only a big bomb was thrown on the pioglitazone as bladder cancer. Now it is almost 10 years over, 10, 50 years, 10, 15 years over. We don't come across earlier also bladder cancer. After that also bladder cancer among pioglitazone users, because I am using and many of our colleagues are using pioglitazone since the introduction of pioglitazone in India, 2000 onwards. We are closely monitoring all our patients. So on top of it, the gliptins also getting added from 2007, along with the metformin, how the gliptin and glitazones are helping our patients to maintain blood sugar. This is the topic of the today. At the end, if you have any doubt or clarification, you can clarify for some time. And I will show some of my own case record also at the end. So this omnibus update we all know, so I don't want to elaborate this. And diabetes management also in ADA 2024. So they have not mentioned anything about metformin. So healthy lifestyle behavior, diabetes self-management education and support, social determinants of health, that's all. So after lifestyle modification, earlier guidelines says metformin. Then 2017 or 18 guidelines says after metformin, sulfonylurea, etc. Sulfonylurea went out from 2018 onwards. Now they have removed metformin also. If patient has atherosclerotic vascular disease or cardiac failure or CKD, accordingly you can prefer SGLT inhibitor or GLP-1 receptor analog, then not getting metformin. Many senior people, the people who cross 55 years of age or 60 years of age only know about it. Chlorformin is combination and bigonite. Of course, Westerners are criticizing this combination. Despite their criticization, we are using this combination. Then we started introducing 11 combined metformin coffee. Diabetes, because number more than 33 years, global awareness not creating any impact. See, global awareness about polio immunization created impact. Now India is free from polio. Global awareness about smallpox eradication had given some fruitful effect. No, polio, sorry. Of course, both are due to vaccines. But cholera without vaccine, we had drastically reduced. Leprosy without vaccine, we had drastically reduced. All many waterborne diseases we have drastically reduced. For example, plague, cholera, dysentery, all many diseases without vaccine also we have tackled. But unfortunately, in front of our eyes, we are allowing the disease to grow every year by year. But otherwise, we have not taken any positive or constructive steps to pull down the incidence or at least avoid the complications. So diabetes incidence also going on, but progressive nature of loss of beta cell function. Of course, up to the year of 2002, no other go, we were persistently stimulating the beta cell, releasing the insulin from the beta cell with the help of sulfonylurea, by which beta cells are getting regranulated or exhausted. And intermittent hyperglycemia or chronic hyperglycemia also will spoil the remaining beta cells. And ultimately, they will end up with insulin requiring phase or total loss of beta cell failure or beta cell function. That was the status. Now we can retrieve the function of beta cells, restore the beta cell function, or avoid further deterioration of beta cells. To that level, our drugs are there. Knowledge also improved in the management of diabetes. So progressive nature of loss of beta cell function, there is an urgent need to protect insulin secretory reserve by preventing or limiting the loss of beta cells or improving the beta cell function and mass. This should be the aim of all young doctors in future. So we have to limit the loss of beta cells or improve the beta cell function and mass. This is 2008 information. So at that time, gliptin got introduced, 2008. So we had limited knowledge about gliptins. We had again limited knowledge about TZD and AGI. No SGLT inhibitor during that time. GLP-1 receptor analog also got it in 2005, but again limited knowledge. Imiglumin was not there. With this TZD, limited knowledge of the gliptin and AGI. AGI, of course, Westerners are not using. So during that time itself, the author has thought about limiting the loss of beta cells or improving the beta cell function and mass. This is now very much possible. Every practitioner involved in diabetes care should understand this, apply in clinical practice. Any preventive or therapeutic approach that would limit or reverse loss of beta cell function in diabetes would have profound effect in mortality or morbidity associated with this widespread disease. Because morbidity and mortality, all of us are aware. Every day people are struggling with the diabetic foot infection, kidney problem, heart problem, or brain problem, so many problems due to diabetes. Evidence suggests that there is a potential role by TZD in preserving and regenerating the beta cell. So TZDs are not only preserving and regenerating the beta cells, whereas sulfonylurea persistently, whether it is your modern sulfonylurea or this sulfonylurea, that sulfonylurea, whatever the sulfonylurea, they persistently stimulate the beta cell. And compared to older sulfonylurea, there is glyventamine and glyphosate. Glyphosate is fairly better and glyphosate is fairly better, but sulfonylurea is sulfonylurea only. But ultimately, they go for beta cell failure, beta cell exhaustion, and glycemic variability, hypoglycemia. All those risks are there, even though slightly less when compared to older sulfonylurea. Whereas TZD regenerates the beta cell, whereas sulfonylurea degenerates the beta cells. That is the difference in management of diabetes. Again, this is 2008 information. So glitazone as a single molecule, especially pioglitazone, triple independent benefit. Clears insulin resistance, all of us are aware. Improves insulin sensitivity, improves glucose uptake in the muscle, reduces free fatty acid, reduces tumor necrosis of alpha and leptin, and increases the adiponectin level, reduces the oxidative stress, reduces the visceral adiposity, converts insulin resistant large adipocyte into insulin sensitive small adipocyte, and controls diabetes, improves beta cell function, reduces beta cell apoptosis, prevents amylin deposition, increases beta cell mass, regranulates the beta cells, improves synthesis and secretion of insulin, reduces pro-insulin level. Whereas sulfonylurea increases the pro-insulin level. Pro-insulin is your atherogenic and reduces the pro-insulin level. And reduces CVS also, decreases LDL and DL, improves the vascular smooth muscle function, reduction in BP, reduction in microalbuminuria, decreases PI activity, increases HDL. Otherwise, it helps to prevent diabetes, it helps to control diabetes, even after developing complications also it helps. But unfortunately, this molecule was misunderstood by many of the practitioners because of some of the article writers. So in animal study itself, severe degranulation of most of the beta cells due to chronic hyperglycemia or sulfonylurea. After exposing to TZD, marker degranulation. Of course, this was criticized by our own colleagues, senior colleagues. Not only this was proved in animal study. I used to jovially tell, human also a form of animal only. So if it is getting proved in animal only, it is being applied to human body. So while animals are getting regranulated, beta cells are getting regranulated, our also will get regranulated. So this we come across in our clinical practice also. I will show at the end. When combination therapy with the sulfonylurea drug and metformin, because as I told you earlier, these were the two oral drugs available up to 2002, just hardly 20 years before. If they fail, treatment with the TZD increases C-peptide concentration, reflecting improvement in the cell function. Further evidence TZD induced preservation of beta cell is documented by the findings of several recent trials in diabetes prevention. This apparent ability of the TZD to regenerate the beta cell, in addition to improving insulin resistance and glycemic control, is the compelling reason to use this agent as initial therapy for type 2 diabetes. Again, this is 2003 information. 2003 bladder cancer article only spoiled the issue. 2003 itself, this is the statement for the TZD. Pioglitazone, the forgotten cost-effective cardioprotective drug. Pioglitazone is a potent insulin sensitizer, preserves beta cell function, causes durable reduction in HbA1c, corrects multiple components of metabolic syndrome, and improves non-alcoholic fatty liver disease, etc., etc. Again, this is 2019 information, 4 or 5 years before. Protective effect of pioglitazone relating to various organs also. 47% reduction in secondary stroke in proactive study. Reduction in the carotid intima media thickness in Chicago study. Reduction of 28% of reinfarction in proactive study. Reduction of 61% of acute coronary syndrome, proactive study. Stop progression of coronary artery atherosclerosis, periscope study. And reduction in MI, stroke, etc. Reduction in microalbuminuria. Reduction in mortality incident patient hemodialysis. Reduction of inflammation and necrobiopsis in NASH. And 50% reduction in the hepatocellular carcinoma. So these are all the various positive benefits of the TZD. Effect of pioglitazone on vascular system and CV respectively. So everywhere, see, pioglitazone has gained popularity after several clinical trials supporting reduction in atherosclerosis, atrial fibrillation, and atherosclerosis-related events. Also positively modulates numerous CV function and risk factors such as BP, blood lipid, and adipose tissue physiology, thus leading to slowed atherosclerotic progression. This is 2021 impression. Effect of pioglitazone on established CV risk factors. So these are all the CV risk factors. So obesity improves the redistribution of fat. Hypertension decreases the BP. Hypertriglyceridemia decreases the TGL. Low HDL getting increased. And small dense LDL converts to large more buoyant LDL. Endothelial dysfunction improved. Hyperglycemia getting corrected. Inflammation reduced. Hypotoxicity reversal. NASH also improves. PI also reduced. Hyperinsulinemia reduced. Insulin resistance improved. Otherwise, pioglitazone is the only true insulin sensitizer anti-diabetic agent, even when compared to metformin. So metformin, of course, it has main effect on the hepatic tissue. In addition to hepatic tissue, pioglitazone has got on muscle as well as adipose tissue also. So that is true insulin sensitizer. Again, this is all 2019 information. Because 2013 article only confused the entire globe. Pioglitazone benefits versus risk. These are all the benefits which we have described. Of course, risk is where weight gain. After using 7.5 milligram or 15 milligram, weight gain is not there. 7.5 milligram is giving therapeutic benefit for Indian patients. Earlier, Westerners were criticizing the 7.5 milligram low dose. Low dose, they are describing it as a mosquito dose or non-therapeutic dose, but it is not so for Indian population. 7.5 milligram giving therapeutic benefit without causing weight gain, without causing cardiac failure, without causing edema. Fully written is also there, not heart failure. Small dose is helping the patient, and bladder cancer not at all established even after 10 years after this article. Rethinking of pioglitazone as a cardioprotective agent, a new perspective and overlooked drug. With appropriate prescription and titration, pioglitazone remains a useful tool in the arsenal of the diabetes management. Why pioglitazone-based combination therapy? Of course, pioglitazone you can combine with metformin. Pioglitazone you can combine with glimepiride also. There are a few brands. Of course, we have to be cautious. Patient may develop hypoglycemia. And pioglitazone, gliptin also can be combined. So pioglitazone is the only available insulin sensitizing agent, has a potent beneficial effect to improve and preserve beta cell function, leading to durable reduction in the HbA1c. Pioglitazone also corrects multiple components of metabolic syndrome. So the combination DPP4 inhibitor, which may also have potential to preserve the beta cell function. See, DPP4 inhibitor, by blocking the DPP4 enzyme, GLP-1 level is getting improved. This improved GLP-1 helps the beta cell or helps the islet cells to secrete insulin in a physiological manner. What do you mean by physiological manner? Whenever the blood sugar goes high, beta cells are stimulated by this GLP-1, insulin is released, alpha cells are suppressed, contribution from alpha cell is being suppressed, and beta cells are secreting insulin, PP blood sugar is coming down. Patient is not taking food or delaying the food. Blood sugar goes down. Once the blood sugar goes down, alpha cells are stimulated by this GLP and GIP. Beta cells are suppressed. Once alpha cells are stimulated, hyperglycemia is getting corrected by glycogenolysis or neoglucogenesis. So DPP4 enzymes are blocked by the so-called gliptins. Because of blocking of DPP4 enzyme, GLP-1 level goes high. This elevated GLP-1, supraphysiological level of GLP-1, persistently help the islet cells to secrete insulin in a physiological manner. Otherwise, I used to call this as physiological control of diabetes with the pharmacological agent. So otherwise, without causing hyperglycemia, with the help of gliptin, we could able to control diabetes. Along with metformin, this combination is doing wonder. Metformin clears the insulin resistance, and metformin helps to synthesize GLP-1. So metformin plus gliptin, both itself is doing a wonderful job. If you combine with the pioglitazone, so already pioglitazone clears insulin resistance, by which glucocorticoid is coming down, insulin resistance is coming down, and it helps the beta cells to go for regranulation and new beta cell formation. So this combination, metformin, pioglitazone, DPP4 combination, or DPP4 metformin combination, or DPP4 pioglitazone combination, they are all centering the beta cells and helping the beta cell go for its original synthesis of insulin. Combination with pioglitazone and potentially attenuate some of the side effects of pioglitazone, particularly lower dose of iron used. Of course, side effects is not getting nullified, but you can reduce the thiazolidinone dose, by which adverse effect of TSH can be avoided. Of course, my request to colleagues not to go for more than 15 milligrams. So 1.5 is doing a wonderful job for, I would say, 70-80% of the patients. Hardly 50% require 15 milligrams. 15 milligram BD, 30 milligram OD, 45 milligram, all those things are Westerners dose earlier. They have again mistakenly used those doses and come to the conclusion. For them, the lower dose is 15 milligram. For us, for Indian, the lower dose is 7.8 milligram. We can go up to 15 milligram. If it is not getting controlled, not upwardly titrated TSD, go for other molecules. Metformin and pioglitazone, which I explained, different insulin sensitizing mechanism both. They have different beneficial effects, several other metabolic risk markers and risk factors for cardiovascular disease. Metformin and pioglitazone, the complementary mechanism of action of thiazolidinone and metformin provide the opportunity for effective combination therapy with the two insulin sensitizing agents. Of course, this we are using it for more than 15 years, this combination. Definitely, especially from my side, I'm using this combination for more since its introduction, doing beautiful benefit for our patients. So pioglitazone elicits long-term improvement in patients with type 2 diabetes compared with glycoside-based regime. So once you pull down the insulin resistance, it is getting consistently maintained when compared to glycoside. Pioglitazone-based regime resulted in improved insulin sensitivity and more powerful insulin sensitivity profile compared with the glycoside-based. Impact of fixed dose combination of pioglitazone on insulin resistance and patient type 2 diabetes. Improved insulin sensitivity, improved significantly in all groups. Metformin plus pioglitazone This is baseline. So after buying metformin, sensitivity is getting very much improved. Whereas fiber also is getting improved because glucotoxicity is coming down because of renal elimination of glucose. Again, this insulin dose getting reduced. If you add metformin, insulin dose getting reduced. Metformin pioglitazone further reduced. Of course, metformin pioglitazone insulin sometimes cause weight gain. Sometimes here metformin pioglitazone, the body weight actually equal. In presence of insulin, the weight may go high, but not to go for insulin. Metformin pioglitazone insulin definitely will cause weight gain. Dapagliflozin, of course, weight is less. Here, body weight, they say it's neutral, but metformin, of course, neutral. Metformin plus pioglitazone, the weight may be slightly higher. But dapagliflozin, definitely the weight will come down, but I do not know why these here both are equal. Dapagliflozin, the weight must be lower. Invariably, the weight is low in dapagliflozin. HbA1c reduction combination therapy, sitagliptin as add-on to metformin pioglitazone. So already the patient is on pioglitazone metformin combination. If you add sitagliptin, otherwise triple drug, HbA1c reduction is very much. Add on to metformin study, add on to pioglitazone. So both sides, sitagliptin, A1C is smoothly coming down. See, A1C coming down is here along with pioglitazone metformin. If you add glimepiride, A1C beautifully coming down. We are not denying that. At the cost of hyperglycemia, at the cost of exhausting the beta cell, at the cost of glycemic variability. Here, beta cells are not getting exhausted. No glycemic variability, no hyperglycemia. That clinical findings we have to understand. Efficacy and safety of sitagliptin added to this combination. To assess efficacy and safety of sitagliptin in combination therapy with metformin and pioglitazone. So definitely the A1C, mean A1C is coming down. Addition of sitagliptin 100 mg to ongoing combination therapy with metformin and pioglitazone lead to significant improvement in the A1C, 2-hour post-meal glucose, fasting glucose, and other endpoints. Triple combination therapy was generally well tolerated with low incidence of hyperglycemia. So I could say even if there is hyperglycemia, this is symptomatic hyperglycemia. They feel hungry. Once they take food, they will become all right. But whereas pioglitazone, metformin, glimepiride or pioglitazone, metformin, 11-time combination will cause sharp hyperglycemia. Sometimes they develop giddiness or unconsciousness also. But here, patient will not develop unconsciousness because none of the molecules stimulate the beta cell. Metformin also will not stimulate the beta cell. Pioglitazone also will not stimulate the beta cell. Sitagliptin also indirectly stimulating the beta cell through GLP-1 in a physiological manner, not pathological, on unphysiological manner. Whereas sulfonylurea stimulates the beta cell unphysiological manner. What do you mean by unphysiological manner? Once the blood sugar enters into the lower side, the sulfonylurea should stop stimulating the beta cells. Whereas even blood sugar is 85, the sulfonylurea will continue to stimulate the beta cells. So that is the difference between the sulfonylurea stimulating the beta cell and sitagliptin through GLP-1 stimulating the beta cells. To compare the efficacy dual and anti-hyperglycemic combination therapy with the type 2 diabetes to find out most efficient and effective method of treating these patients. Sitagliptin, pioglitazone demonstrated similar improvement in glycemic control in type 2 diabetes whose blood sugar had been inadequately controlled with metformin alone. Sitagliptin was more effective than pioglitazone regarding lipid and body changes. Again, to evaluate which triple oral between metformin, pioglitazone, and sitagliptin, metformin, pioglitazone, glebenclamide. Of course, they have not mentioned about hyperglycemia here. Both may control diabetes, both may correct blood sugar, but hyperglycemia and glycemic variability is the problem. Sitagliptin should be preferred to glebenclamide as addition metformin plus pioglitazone combination for its better protection of beta cell segregation and its neutral effect on body weight, plus to avoid hyperglycemia. A randomized double-blind study evaluating sitagliptin versus glebenclamide in type 2 diabetes patients already treated with pioglitazone metformin. This study evaluated oral drug combination improving glycemic control compared to the metformin monotherapy, metformin and pioglitazone combination. Sita should be preferred to glebenclamide. Of course, now the entire India, the sulfonylurea market, especially glebenclamide market is already gone. But glimepiride market also now. In my practice also, after introduction of after reducing the cost of sitagliptin, vildagliptin, dapagliflozin, almost for 30%. So long-term efficacy and safety of the sitagliptin plus pioglitazone in type 2 diabetes. Initial combination therapy with the sita and pio provided greater glycemic control than either monotherapy significantly. And this combination, earlier, no other go, we have to combine metformin with sulfonylurea. Now, metformin with sulfonylurea, instead of sulfonylurea, metformin gliptin, metformin pioglitazone, or pioglitazone gliptin, smoothly controlling diabetes without spoiling the beta cell function. Triple therapy with the sitagliptin greatly improved beta cell function, measures compared to glibenclamide, and also compared with the net plus of bio-dual combination also. This clinical finding or clinical observation, few of my case record I will show at the end, how beneficial these molecules are in long-term use. Sulfonylurea long-term use causes beta cell failure, but sitagliptin, pioglitazone, metformin long-term use preserve the beta cell function. We are not using insulin for many of our patients, even though the duration is more than 20 years, 25 years. Again, the long-term efficacy and safety of sitagliptin, pioglitazone. Sitagliptin combination enhanced beta cell function, increasing post blood sugar level, and the study also giving the same finding. Efficacy and safety of initial combination therapy with sitagliptin and pioglitazone in patients type 2 diabetes, best study, that is before and after A1C. And this is A1C and fasting blood sugar. This is extension up to 54 weeks. So, of course, these studies to give us confidence 1 year only. But we have studied for more than 10 years, 15 years also, our own clinical observation. Comparison of DPP4 inhibitor and pioglitazone combination therapy versus pioglitazone monotherapy in type 2 diabetes. Combination therapy was associated with increased HbA1c reduction, fasting blood sugar reduction as compared to monotherapy. Combination therapy was not associated with other reduction in edema. Combination therapy was associated with better improvement in the pancreatic beta cell function. Again, the combination therapy with sulfonylurea will cause beta cell destruction or beta cell degranulation, whereas combination of metformin plus pioglitazone, combination of pioglitazone plus sitagliptin preserve the beta cell function. Once you preserve the beta cell function, definitely the physiological control of diabetes will be there. Glycemic effectiveness in dual combination therapy with sulfonylurea, pioglitazone, or DPP4 in drug-like orientation. Of course, category 1, category 2, category 3. But combination with glibenclamide, sulfonylurea, A1C reduction may be same. But as I told you earlier, a minute. No. Right. But glycemic variability, hypoglycemia is quite common. Group 1, metformin and either diclofenac or glimepiride. Group 2, metformin, 50 mg pioglitazone. Group 3, metformin and 100 mg. Of course, all are achieving A1C level 83%, 87%, 86%. But whereas in glycoside or glimepiride arm, the glycemic variability, beta cell degradation, hypoglycemia risk, they are not mentioned here, but it is definitely there. But it will not be there in the other two arms, metformin plus pioglitazone, metformin plus sitagliptin now. Same thing here also. Group 1, metformin, either glycoside or glimepiride. Group 2, metformin and pioglitazone. Group 3, proportion of overall successful control. Again, almost same. But again, as I told you earlier, because of glycoside and glimepiride, they have their own drawbacks. Regarding cancer and pioglitazone, diabetes and cancer, hyperinsulinemia is the leading hypothesis underlying the association between type 2 diabetes and cancer. Otherwise, insulin resistance causing hyperinsulinemia. Hyperinsulinemia has got two mechanisms, proliferative mechanism. One is cancerogenic, mitogenic, and another one is growth factor aspect. So in that, obesity, insulin resistance per se invites cancer, whereby elevated insulin level in type 2 diabetes stimulate insulin receptors on cancer cells, promoting cells, cancer cell promoting cells, division and growth. This is 2010 information. TZD have been noted to have PPR gamma agonist independent anti-cancer effect. Cellular experiments and animal studies have shown promise for TZD in preventing or reducing various cancers, and clinical trials are now testing TZD as possible therapy for lung, breast, and other cancers. So to that level, TZD is having positive effect on the cancer. Pioglitazone and cancer, study finds no increased risk of bladder cancer with pioglitazone. Overall cancer risk actually 32% lower in glitazone group and 22% lower in metformin group. Retrospective data of more than 25,000 female patients from the Cleveland Clinic. Again, pioglitazone and cancer, the absolute risk is low and backed by the risk of other serious adverse outcome of diabetes or probably improved by pioglitazone. In more than 6 lakh type diabetes patients, used pioglitazone associated decreased incidence of ratio 0.83. The protective effect was stronger for higher cumulative dose and for longer treatment duration. A decrease risk of colorectal cancers for TZD users compared to never used TZD. Hazard ratio of 0.86. If it is less than 1, better. PPR gamma again has anti-neoplastic effect in colon cancer. This is wrongly put. A study in US vegans among TZD, 33% reduction in lung cancer when compared to non-users. Hazard ratio is 0.67. The Cleveland Clinic also shows reduction for lung cancer with TZD and metformin. Hazard ratio 0.47. Again, this global versus Indian perspective, a comparative retrospective pharmacology analysis for cancer. Metformin itself has anti-cancer potential and its use along with pioglitazone may contribute to the prevention of blood cancer. This is 2019 information. Pioglitazone is safe in Indian study also. Pioglitazone in combination with other OAD in Indian patients was an effective treatment protocol in glycemic control. Reduction in the fasting PPA1 also help in controlling weight gain in patients with TDM. In this patient population, there was no bladder-related abnormalities. Pioglitazone was safe and efficacious addition to treating the patients with polycontrolled type diabetes. No increased risk of bladder cancer with pioglitazone. Again, this is 2015 information. Total of 283 incidents of bladder cancer, 130 were in the exposed group, 153 in the non-exposed group. So you need not worry about bladder cancer because many practitioners all over India worried about bladder cancer. Pioglitazone is triple combination therapy targeting omnious octave. So where beta cell function is declining, alpha cell activity is going high, hepatic glucose output is getting increased, incretin effect is less, and insulin resistance at fat tissue, reabsorption of glucose in the renal tubules excess, insulin resistance in the hepatic tissue, muscle tissue, and neurotransmitter dysfunction. These are the omnious octave. To correct that, DPP4 improves the beta cell function, and DPP4 improves the incretin level in circulation, GLP-1 level. Metformin and TZD clears insulin resistance in the muscle tissue. And metformin and TZD helps the hepatic glucose output reduction. And DPP4 inhibitor suppresses the alpha cells also. And metformin and TZD that helps the clear adipose tissue. Otherwise, metformin, TZD, DPP4 correct almost all pathophysiology except your 6th one and 8th one. Of course, 8th one is negligible one. 6th one, if you add, if you want, inhibitor, all 8 are getting corrected. All 8 are getting corrected. Almost here, 6 are being covered by these 3 molecules. So, a few of my 1 or 2 cases of my own. This patient here about 1961, 1993, at the age of 32, he developed diabetes. He saw me only in 2009. So, 93, after 16 years of diagnosis, 2001, his A1C was 9.1, gross glycemic variability. Again, gross glycemic variability, A1C 8.9, 9.6. On May 2009, 15 years before, 9.2. He was on glycerin and metformin combination, premix insulin, 20 minutes morning, 10 minutes night. With this background only, he visited my clinic on 16/5/2009. Of course, premix insulin, 20 minutes morning, 10 minutes night. Pioglitazone I added. Pioglitazone, glycerin and metformin combination. Glycerin and metformin combination I was continuing. And Voglio was also added. So along with the existing combination, see, up to 2000, I have told you earlier, we had insulin, metformin, sulfonylurea. From 2000 onwards, our Voglios came to market and pioglitazone came to market. After adding these 2 molecules along with the insulin and sulfonylurea, this was the ulcer not getting healed. See, July 76, 109, 84, 112. We stopped night dose insulin, morning dose insulin only 10 minutes. Of course, 11-gramide metformin pioglitazone combination continued. 11-gramide metformin night dose continued. Voglio continued. Then 136, 125, 6.8, we stopped insulin. See, patient was on insulin for 6 years. We stopped insulin. We reduced sulfonylurea dose also 2.5 milligram in the morning. Night dose sulfonylurea we stopped. Introduced sitagliptin. Voglio was continued. Then before dinner, after dinner, before lunch, after lunch, 5.9. Here we stopped sulfonylurea also. Otherwise, we could able to de-prescribe insulin. We could able to de-prescribe sulfonylurea. This message all clinically oriented practitioners should understand. Because article writers are writing so many things. And guideline makers are also giving so many guidelines. But clearly, what is happening in day-to-day clinical practice, that is very important. How these molecules are helping us to remove insulin, to remove sulfonylurea. Once you remove those 2, the beta cells are going for natural function of beta cell function. And without causing hyperglycemia, without causing glycemic variability, A1C near to physiological range. So 6.5 again, 6.5, metformin combination, glucose. See, again, glucose. In addition to preventing the digestion of carbohydrate, disaccharide is not getting converted to monosaccharide, 30%. So PP blood sugar is coming down. This undigested disaccharide stimulates the cell is GLP-1. So GLP-1 from AGI, GLP-1 from metformin, and predominantly from the gliptin. Persistently helps the beta cell to go for cell synthesis. Again, pioglitazone helps for regranulation, new beta cell formation. By this mechanism only, without insulin, without sulfonylurea, beautifully the diabetes is getting controlled, even though the duration is now more than 20 years. 93 patient development. 2003, 2013 war. So 6.1, 6.4. So restoring the beta cell function. Type 2 diabetes since 1993 was on sulfonylurea, metformin, then insulin was added from 2006, labeled as insulin requiring type 2 diabetes. Now getting controlled persistently without sulfonylurea and insulin, but with sitagliptin, metformin, glucose combination, and pioglitazone also. Sorry. One minute.
So you just have to go to your PowerPoint, sir.
1 minute. Is PowerPoint is visible now?
Yes, sir. So we need to put it on full screen, sir. Full screen is not visible.
1 minute, 1 minute. I will come back.
Yes, yes.
Right. So metformin DP4 inhibitor, metformin increases GLP-1 and DPP4 inhibitor reduces GLP inactivation, that is by improving the GLP. So both are contributing for control of diabetes along with the pioglitazone. This patient A1C was persistently 9. Now A1C is persistently normal. Otherwise, you could able to pull down the A1C and maintain the A1C at normal level. We need not allow the A1C to be always at higher side by modern treatment. Especially these are all possible after 2005 or 2002 only, or after the arrival of these newer molecules. This ulcer was not getting healed for 6 months. Now totally getting. Once the tissue glycation comes down, see, blood sugar we can measure, HbA1c we can measure, but the attachment of glucose into the protein tissue we cannot measure. So attachment of glucose into the protein tissue only causing all these damages. This ulcer we could able to see, but kidney damage, liver damage, or heart damage, eye damage cannot be seen. So once you control and pull down the A1C and maintain the A1C, tissue damage also getting recovered. Otherwise, tissue glycation is coming down. Once tissue glycation comes down, wound is getting automatically healed. This is another patient. 60 year after 2006 patient came to me. 160 2006, pioglitazone metformin combination 15 milligram, fasting 168, 1 hour of glucose 420, 400. 23/6 itself, 89, 93, 60. A1C was at the time 8.2. So from 15 milligram, we reduced to 7.5 milligram. We don't have 7.5 milligram now. And 85, 170, 7.5 also reduced half. June, July, September, 107, 107, 120, 107, A1C 5.6, we start pioglitazone. Only results are. So people are taking this as a reversal. Reversal is happening, but we cannot market or we cannot make money out of it. The same reversal should get maintained throughout his life. That is very important. From 2006 to now 2024, 71, 51, A1C 6, diet advice, Up to 2012, he was maintaining. Then people started criticizing him. Why are you not taking sweets? Why are you not taking this? That he was not following the diet advice. 2013, again 2.7, 415, A1C 13.9. This is what happening in day-to-day clinical practice. We have to track the record. We have to ask for history. Patient may change the doctor, but doctor should ask the history. Go through the record. Then pioglitazone metformin again introduced. Sorry. So pioglitazone metformin again introduced. Here AGA also introduced it. So within 1 month, see, November. But what literature says, once fasting blood sugar double normal, BP is double the normal, A1C double the normal, you have to treat them with insulin. But if you withdraw the excess, the glucose-rich diet or energy-dense diet, but pioglitazone metformin may ignore without insulin. Next month itself 107, 162. See 105, 146, A1C 6.3, 6.6, 6.8, 6.7, 5.8, 5.2 also, 5.5, 5.7. So the message is, if you are able to pull down and maintain the A1C, if they don't hurry to diagnose, again shoots up, they are to treatment level. Even if it goes high, you can able to pull down and maintain the A1C. So this patient was on metformin bio initially because pioglitazone stabilizes the beta cell function. Then in between diet advice, not followed the diet advice, then we added metformin bio AGI. With that, we will get controlled. So earlier treatment only initially A1C comes down, then start going because of sulfonylurea. After the arrival of once we pull out, it is possible to maintain. And after the arrival of gluten, it is possible to maintain the A1C persistently throughout their life. And acute GLP level effect, chronic GLP-1 effect level on the beta cells. Acute is insulin secretion is getting improved, glucagon is getting suppressed, insulin production, beta cell survival are improved. So because of DP4 effect, DP2 effect. So pioglitazone, in addition to exerting sustained glucose firing effect, also has anti-metabolic action, potential interest in addressing cardiovascular disease, has preservation of beta cell mass and function. As such, it is a logical agent combined with other oral antidiabetic agents, including DP4 inhibitor. This is 2018 article. DP4 inhibitor which also have a potential to preserve beta cell function, available in the fixed dose combination with pioglitazone, and to potentially attenuate some of the side effects of pioglitazone, particularly the low dose of used. This review critically discussed the potential for early combination of pioglitazone and DP4 inhibitor. So summary, the magnitude of therapeutic options for T2DM adds to complexity of the management of patients with disease, but allows clinicians to readjust and rebalance treatment for the time as physiological changes occur throughout the course of the disease. So that only we have to encourage the patient, they should come for regular follow-up. Whether they are following this doctor, that doctor, this hospital, that hospital, they should have the regular follow-up. So that will be better to go for separate notebook for diabetes or some follow-up booklet for diabetes. Then only we can go to the records. As understanding of the physiology of type 2 diabetes grows, it is becoming apparent that early use of targeted combination therapy has the potential to slow disease progression, potentially through the correction of known pathologies and preserve the beta cell function. So this preservation of beta cell is very much possible. As I told you earlier, even though I am in practice from 82, but 82 to 2005, this concept was not at all applicable. If somebody thought that we are going to preserve, no, beta cell are programmed to die. So UKPDS has beyond approved at the time of diagnosis, 50% beta cell lost. Remaining 50% at the rate of 4 to 5% per annum, with 10 years, the remaining beta cell also go off. We have to treat them with insulin, they land up with complications. These are all the area story. Because UKPDS used only these class of drug, metformin, sulfonylurea, and insulin. After UKPDS, we have 6 new class of drug. We have reached experience so many articles, so many guidelines, and our own clinical findings. Whereas underlying physiology of type 2 diabetes should be a key factor in choosing which medication to combine. The treatment choice must also be individualized. This is very important. So sometimes patient may develop weight gain, period edema, breathlessness, all those things we have to keep in our mind while use pioglitazone. Based on the individual therapy profile, new therapies are appropriate for use in combination with more traditional agents. Of course, metformin traditional agents, this is not again for me new agents only to use. Emerging evidence support and advocate for use of early combination therapy. Again, even if you use early combination therapy, patient should adapt to diet advice. Patient to do exercise. Without doing these two, simply following combination is not going to help the patient. So you have to continuously encourage the patient to adapt the diet advice, do some exercise, on top of it, they take medication, and they have to monitor. That is very important. Not only they know where they are, we also know where we are. So this is about today's topic of pioglitazone plus gluten. Thank you very much for Emcure and the team and my colleagues who attended the session late tonight. Thank you.
Thank you, sir. Thank you for that insightful presentation. So now we will take up the questions which were posted in the comments box. I can already see a few questions which are there in the comment box. So one question is, what is the best test in routine practice to check for insulin sensitivity?
Insulin sensitivity again go IR only. But again, for theoretical purpose or study purpose, we can check. But again, in day-to-day clinical practice, it is not going to help. So to improve insulin sensitivity, what you should do, you should ask your patient to go for 15 minutes, 30 minutes, or max 1 hour of physical activity. That is physiologically improving the insulin resistance, reducing the insulin resistance, improving the insulin sensitivity. So like blood sugar monitoring, like your urea gate monitoring, you need not monitor insulin sensitivity. Similarly, insulin resistance also, HOMA IR, HOMA insulin sensitivity, HOMA S. So there is a calculation, but you can apply theoretically, but in day-to-day clinical practice, it doesn't require a calculation or etc.
So then there is
also used to say like this. Some of my patients which I have shown to you, at the time of initiating insulin, before initiating insulin, they do CPAP, right? CPAP is negligible. Your beta cell had already lost. No other go. You have to continuously take insulin. This is a message some of our colleagues are even now telling. But with the help of new drugs, they are negotiating to withdraw insulin. Beta cells are not totally dying. Beta cells are failing. So I used to figure it like this. The tree on look dry, but the trunk is still alive. Branches only dry. With the help of alive trunk, you can create new leaves. Similarly, beta cells are failing, not dying. This exhausted beta cell regranulate, and by regranulating, you react to the beta cell, then go for natural synthesis. So you need not measure C-peptide level, insulin sensitivity level, as well as insulin resistance on everyday clinical practice. Once in a while, you can measure and make a note of it.
So there is another question which is asking that what would be the ideal patient profile to use pioglitazone, metformin, sitagliptin combination?
Yeah, ideal patient is already patient is on metformin, sitagliptin, well and good. Mostly there is no drawbacks with these two molecules. But once you add pioglitazone, the patient is obese, even though there is indication with clear insulin resistance, sometimes the weight is getting improved or increased in such group. For obese people, ideal agent along with metformin, sitagliptin, dapagliflozin only. For non-obese people, even though they are non-obese, there is some amount of insulin resistance. You can add this molecule. Before adding this molecule, if there is any cardiac failure symptoms or ejection fraction is less than 60, we have to be cautious. So ejection fraction must be more than 55 or 60. And despite that, if you want to add, you can go for 7.5 milligram, then you can closely monitor. Suppose weight gain is that your ejection fraction is coming down, better remove this 7.5 also. Ejection fraction is better and no harm in giving 7.5 milligram or even 15 milligram for such people. So they are beautifully getting controlled. Metformin, sitagliptin not controlling. There is no contraindication for pyrrolidazole. You can beautifully add then monitor the patient. So by which beta cells are protected, beta cell will go for long duration of action.
So then, at what HbA1c should a triple combination be initiated in a type 2 diabetes mellitus patient?
Yeah, A1C 8 and up to 9. See, before that, just 10 or 15 years before, if A1C is more than 8, we have to start on long-acting insulin. We have to pull down the blood sugar, then go for oral drugs. Like that, we are teaching. We have been taught. Even 15 years before the introduction of long-acting insulin, if there is glucose toxicity or A1C is more than 9, no need of not to prescribe sulfonylurea. Sorry, oral drugs. Start them on insulin. Now, even though A1C is more than 8 or even 9, you can prescribe triple drug. You can prescribe triple drug confidently. But on top of it, as I told you earlier, if one type patient is continuously taking some storage diet, not adequate diet advice, even after initiating insulin is not helping. So even the A1C is 8 to 9. But suppose more than 9, for example 10 or 9.5, better give insulin. Reduce the glucose toxicity, then go for this combination. Less than 9, you can give triple drug combination and monitor the patient. If the response is adequate after 3 months, that is from 9 it has come down to 7.5 or 7, you can continue this triple drug combination. But despite triple drug combination and diet advice, still A1C is 8.5 or 9, better add insulin.
So then there is, so you already shed some light on this, but there is a question stating that what could be the advantage of pioglitazone plus DPP-4 combination over the other available combinations which are there in the Indian market?
Yeah. See, the combinations are available, multiple combinations are available in the Indian market. So as I elaborated earlier, metformin, benprine, before that metformin, bentamide, before that chlorpheniramine or benformin. Then only metformin, pioglitazone came in. Then only metformin, pioglitazone, sitagliptin are coming in. So depending upon the clinical condition of the patient, you have to choose. For example, patient is on regular follow-up. Already patient was started on metformin, for example, alpha-glucosidase inhibitors, 1 day, not in control. Here you are adding sulfonylurea. Instead of adding sulfonylurea, you can add gliptane. Despite adding gliptane, not getting control. Again, instead of thinking about sulfonylurea, you can add pioglitazone. During this process, so metformin, pioglitazone, or gliptine combination is there. Go for single molecule, so single pill. So patient compliance is there. So like that, you can prefer the choice now. Otherwise, without sulfonylurea, there are multiple options along with metformin now. But you have to choose the patient. You cannot do this combination everybody.
So then there is a question specifically regarding the combination. So what are the ideal patient profiles for for sitagliptin, pioglitazone, metformin, sitagliptin, glimepiride, metformin, and sitagliptin, dapagliflozin, and metformin combination?
Yeah, sitagliptin, metformin, dapagliflozin combination. As I told you earlier, patient BMI is more than 25 or 26. There is no UTI, neuroposthitis, or vulvovaginitis. So without waiting for your so-called CKD, so-called obstructive vasculitis, you need an expert all those things. If you give this combination, beautifully the single pill, 3 molecules doing wonder in these patients. Patient is non-obese, body mass index is less than 25 or 24, 23. There is zero obesity, some amount of resistance will be there. And there is no contraindication, especially cardiac failure symptoms are there, not there. And your ejection fraction is more than 55 or 60. Such you go, metformin, pioglitazone combination is good. But metformin, glimepiride, sitagliptin, I don't prefer because after adding pioglitazone or ogibos or DP4 inhibitor or FGF inhibitor along with the existing metformin sulfonylurea combination, because I am practicing as I told you earlier long years. Many of my patients were on metformin sulfonylurea combination. After adding this 4 class of drug, I am confidently saying 30 to 40% of people I stopped insulin. I stopped sulfonylurea, which I showed you earlier. Well, such these things so why should I go for glimepiride combinations? And deprescribe of sulfonylurea, deprescribe of insulin. Otherwise, low dose user of sulfonylurea, low dose user of insulin.
The last question I think it is how to identify insulin resistance in diabetes patients clinically, as in clinical science.
Yeah, clinically, looking at resistance, physiologically, after the age of 35 or 25, many of us are insulin resistant people only. Because earlier we were physically active. But after the arrival of your cell phone, smartphone, computer, TV, remote, etc., physical activity of the global population had drastically come down. So once the body mass index is 24, 25, they start developing insulin resistance. So this is the clinical clue. Then if you want to scientifically prove, there are various methods to prove. But once the simple height and weight, body mass index is 24, 25, 26, 28, there is insulin resistance. So for home, you have to ask them to do exercise of not 1 hour, ask them to go for energy low diet, or instead of going for energy dense diet, plant-based fiber-rich diet, come for ideal body weight, be active, be fit always. Then insulin sensitivity will improve, resistance will come down, all your metabolic parameters will become normal, they will not have metabolic disease.
So is there any role of pioglitazone combinations in diabetes with NAFLD patients?
Yeah, NAFLD is definitely helping, but for the NAFLD is quite common obese people only. Non-obese people is there, but quite rare. But NAFLD is very rigorous, there is no doubt. But in case of obese people, see, my clinical observation is 7.5 is not causing that much increase in weight. 15 milligram, 30 milligram again putting on weight. So water retention is more once you go for 15 or 30. So that only one of the better is available. SGLT inhibitor is available. SGLT is available. Even though there are articles saying that NASH is getting regression in 500 but beautifully SGLT inhibitor and DL2 are doing wonderful job in reducing the weight and reducing the NFLD. Earlier we didn't have option.
Thank you, sir, for all the answers. So we are almost at the end of today's program. But before ending, let us thank all those because of whom the program was possible. So I would like to express my deepest gratitude to our distinguished speakers, Dr. A. Paniraselvam sir, for his insightful presentation. Your deliberation has undoubtedly expanded our understanding pertaining to diabetes management using pioglitazone-based combinations. I would also like to thank our esteemed audience for their active engagement and for making this program a resounding success. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing, and the medical team at Emcure who have contributed for the success of this program. Let us carry this knowledge into our practices, research, and advocacy, fostering a healthier future for patients with diabetes. Thank you once again for attending and encouraging us. Good night and a good time ahead. Thank you.
Thank you, sir. Thanks. Good night, sir.
Right, sir.
Recording stopped.